is very relevant to understand some of the important clinical evidence that has accumulated over the period of last decade or so on the topic of on the space of SGLT2 and the GLP receptor agonist. So the focus will be basically on the SGLT2 and GLP-1 receptor agonist. For long, we have understood that we have been focusing on glycemic control alone, but subsequently during the course of analysis and our own approaches, we found that the patients with diabetes have had significant cardiovascular morbidity, and therefore they also have a clustering of various cardiovascular risk factors. And this puts them, along with this diabetes as a significant comorbidity, at a premature risk of cardiovascular disease, cardiovascular mortality, and also various peripheral arterial disease and heart failure. We come to know in the last 7 years or so that peripheral arterial disease followed by heart failure is a significant initial manifestation of the cardiovascular disease occurrence in diabetic population, and therefore various studies have addressed whether one of these therapies addressing the glycemic control would also confer a significant enhancement of the risk, or is it safe for the patients who are already having a background of cardiovascular disease risk. So this is a meta-analysis of the various HDL-T2 trials, which was published in the Lancet in 2019, and it showed that the EMPA-REG, Canvas, Declare, TIMI, Credence, and Vertis CV all consistently showed in a pooled estimate that the trials or the agents, the HDL-T2, significantly reduce the first occurrence of the major adverse cardiovascular events. And that was very, very consistent across all the diabetics who have a high cardiovascular risk subjects. Now, if you look at the heart failure hospitalization, the consistency of benefit was much significant. And you will see that almost 32% relative risk reduction from use of SGLT2 in diabetics in reducing the heart failure hospitalization, which is one of the most important determinant of the survival of a patient with a significant cardiac morbidity in the form of a heart failure. Now, if you split up all these trial manifestation or the trial endpoints, you would see that the EMPA-REG, Canvas, Declare, TIMI, and Vertis, all these agents of SGLT2 and the trials, one thing was just consistent was a significant reduction in the heart failure hospitalization, which is seen here to the extent of 30 to 35%. But what was not consistent was on the mortality of the cardiovascular death, whereas empagliflozin reduced the mortality, cardiovascular mortality. The other SGLT2 did not bring down the cardiovascular mortality in patients who have diabetes with established cardiovascular disease and all or the risk factors. The major adverse cardiac events did come down with empagliflozin and also the canagliflozin. So subsequently, the trials addressing the SGLT2 in those with or without diabetes, but having baseline heart failure, or who had had an episode of decompensated heart failure or a de novo heart failure, were randomized into placebo versus SGLT2. In DAPA-HF, it was dapagliflozin, and EMPEROR reduced, it was empagliflozin, and patients were to have a ejection fraction of less than 40%. And again, both these trials consistently showed there was a remarkable benefit to the extent of 25 to 26% relative risk reduction of the heart failure hospitalization and also cardiovascular morbidity, and which was consistent with the use of SGLT2, which is very safe and proven to be very effective in reducing the hospitalization cardiovascular morbidity if a diabetic subject has a heart failure. So the SOLOIST trial is a recent trial with sotagliflozin, which again consistently showed a significant reduction in the cardiovascular death, heart failure hospitalization, and urgent heart failure visits. And this is to the extent of, again, 33%. So it was much more effective. The sotagliflozin also has a dual benefit on the SGLT1 inhibition, and therefore we are hoping for more trials to come and show that the sotagliflozin, with an additional benefit of SGLT2 as well as SGLT1 inhibition, would confer a significant benefit to give us a choice of which among the SGLT2 would be a preferred drug for the heart failure reduction and cardiovascular mortality reduction in diabetic patients who have a heart failure. Now, if you look at the cardiovascular outcome of all the GLP receptor agonist, we would look at the LEADERS trial, the dulaglutide, REWIND, and SUSTAIN. and the oral semaglutide trial Pioneer. And all these distinctly showed the major adverse cardiovascular events were consistently reduced to the extent of 20 to 23%. So, whereas a semaglutide brought down by 26%. The oral semaglutide on the Pioneer also showed a 21% reduction in the cardiovascular outcome or major adverse cardiovascular events. And this was particularly driven by myocardial infarction and stroke reduction. Now, the major adverse cardiac events with the GLP-1 receptor agonist trials, all put together with the available trials, showed a consistent pooled benefit of 22% relative risk reduction of the major adverse cardiovascular events with the use of um, uh, the GLP receptor in patients with diabetes and also significant underlying comorbidities with the cardiacs. So the SUSTAIN 6 is the semaglutide also showed that distinct primary outcome, non-fatal myocardial infarction, and also the non-fatal stroke was significantly reduced, whereas it did not affect the mortality from cardiovascular disease. So the major adverse cardiovascular events, non-fatal myocardial infarction, and stroke, particularly stroke, non-fatal stroke was significantly reduced. So they showed that there was an additional benefit of GLP receptor agonist on the neuroprotective effects in cerebral atherosclerosis and also reducing possibly vascular dementia or even sometimes looking at the extended benefit in the Alzheimer's disease. So the non-fatal stroke, if you see among all the pooled analysis, overall the use of a GLP receptor agonist therapy brings down the relative risk reduction by almost 26%, with 16% with the use of GLP in patients who are diabetic. So there was a significant reduction in the stroke reduction itself. Now, looking at the HDL T2 and heart failure, which was already discussed, I would go into a little more in detail about the continued use of HDL T2 in sugar DM heart failure, as well as the Empire heart failure, which looked at some of the remodeling effects. So it does confer significant benefit in the form of remodeling of the left ventricle in various parameters of the end-diastolic volume, end-diastolic systolic index, the left atrial volume, and ejection fraction, which over a period of time significantly improves the cardiac performance. Now, this is the DAPA-HF and Emperor reduce, which was consistently showed a benefit of cardiovascular death and heart failure reduction in the heart failure hospitalization, and also the mortality reduction with the cardiovascular death and all-cause mortality was also reduced consistently across both the groups of dapagliflozin and empagliflozin. Now, the SOLOIST trial again showed a 33% reduction of a combined heart failure and heart failure hospitalization and cardiovascular death. And it was consistent across all the subgroups of patients who had higher heart failure in the regardless of the ejection fraction, regardless of the diabetic and the gender differences, and also the age and eGFR. Now, the Deliver and the Emperor Preserve looked at the usefulness of SGLT2 in people with the heart failure with preserved ejection fraction, by which I mean that ejection fraction is above the 50% mark and or 45 to 50% mark. And again, among the diabetics as well as the non-diabetics with the HFpEF preserved ejection fraction heart failure, there was a consistent benefit by 20% in the heart failure hospitalization and 18% reduction in the cardiovascular death, which was also seen with the empagliflozin significantly. So there was a consistency in that. Now, finally, to conclude, I would say the SGLT2s are very, very important drugs in the management of heart failure, as well as in the management of diabetics with cardiovascular risk factors, and also diabetics with heart failure at baseline or without heart failure at baseline. And it significantly enhances the outcome in both patients with reduced ejection fraction and preserved ejection fraction. With regard to the preserved ejection fraction, we did not have any significant molecule modifying the outcome in patients with HFpEF till now. And this is the only considered molecule which is found to have a favorable impact on the survival as well as the hospitalization reduction with the SGLT2 use in patients with the heart failure. And that is regardless of whether patient is a diabetic or not diabetic. However, we certainly do not know the exact mechanism by which the SGLT2 confers a significant cardiovascular favorable benefits, which are not clear at this point of time as we discuss this. The dual inhibition, as I said, with the sotagliflozin, with the HDL-T1 inhibition and HDL-T2 inhibition, is a very promising approach and needs to be seen in the subsequent years. Now, all this put together, the ADA standards of medical care for diabetes for the clinicians involved in the diabetic care distinctly have to look at whether the diabetic patient has an established cardiovascular disease, or they also have a high cardiovascular risk factors, or they have a high heart failure or CKD. The CKD aspect would be discussed by for the following speaker by the nephrologist specialist. But I would look at if the individual with the diabetes has a established cardiovascular disease, or there are indicators of a high cardiovascular risk in the subject with diabetes, you have to initiate a GLP-1 receptor agonist and also SGLT2. So if the glycemic targets are above the goal, you may have to optimize the doses of the GLP-1 receptor agonist and also add other intensification of the lifestyle therapies and also patient-centered treatment factors and the dietary factors, and also consider the DPP4 inhibitions. Now, if the diabetic patient has a baseline history of heart failure, then SGLT2 becomes the important drug to be added upfront. So these are the important considerations. With this, I would leave it for the open discussion. Thank you for the attention.